Good evening. This is Dr. Rahul Desai. I'm a consultant diabetologist at Advanced Diabetes Care Valsad and Advanced Diabetes Care Vapi.
How does Imeglimin fit into your regular practice with the current landscape of T2DM treatment options? Kindly share your experience.
So far, I have had a very good experience with Imeglimin, especially in patients who have had metformin, haven't tolerated metformin too well or have an allergy to that molecule. But even with metformin, I have used in certain patients, and the results have been pretty good, especially where a very small up titration of dosage is required. Adding Imeglimin in a BD dose has really been useful for me in my clinical practice.
In what specific patient population do you see the greatest benefits of using Imeglimin?
Correct. Like I just mentioned before, I think the greatest benefit will be in patients who either do not tolerate metformin or have an allergy to that. So these are the patients who are ideal patients to start Imeglimin, because the action of Imeglimin and metformin is pretty similar. The only difference is that Imeglimin acts on a very molecular level. So there might be a lot of pleiotropic benefits to it which are yet to be known. So they are already under scrutiny. So let's see where that is.
How does Imeglimin compare to other hypoglycemic agents in terms of safety and efficacy? You can share a real world case if any.
Correct. See, in terms of efficacy, I would say that so far my clinical experience has been decent. It is not one of the most efficacious or potent drugs in terms of an anti-diabetic agent. But when it comes to safety, it is pretty safe. I've barely encountered anyone who has had any side effects with Imeglimin. One or two patients probably had some mild GI disturbances, which was resolved within the first couple of days or first week, and nothing that couldn't be managed by an antacid or something like that, and that too very quickly they start tolerating it. So the safety profile is pretty good. Efficacy, I wouldn't say it is one of the most efficacious, but does the job.
In recent time, Imeglimin sustained release formulation with Indian study has been launched in India. What is your opinion on that?
I am personally not in favor of launching a twice a day molecule as an SR in their SR forms. I've faced a pretty same opinion even with vildagliptin, when the original dose being 50 BD and then they launched as a 100 SR. My clinical experience wasn't that great, and I think my opinion will be the same for Imeglimin as well. I would rather give the patient 500 or 1000 BD than giving them 1000 OD in an SR form.
How does the mitochondrial targeting mechanism of Imeglimin influence its clinical use?
So basically what happens is that when it is acting on the molecular level, it not only helps in fighting insulin resistance, like increases insulin sensitivity, but it is also theoretically proven that certain actions that happen on the molecular level also increases the production of insulin. So by far on that level, Imeglimin becomes the first drug that not only acts on insulin resistance but also on insulin secretion. So far we have never had any drug that acts on both pathways. In fact, I have also read somewhere that Imeglimin is also being studied for its action on molecular level with respect to sexual dysfunction, because what happens is that when it is acting on molecular level, it also helps in proper vascular functioning. So there are a lot of benefits that could be eventually evaluated with Imeglimin but are currently only theoretical or hypothetical. So the only molecular level theory that currently holds true and which is clinically relevant is that it acts both on insulin secretion and insulin resistance.
What are the key safety and efficacy findings from clinical evidences on Imeglimin that clinicians should be aware of?
With terms of safety, I don't think there is much of an issue. The only place where we should avoid Imeglimin is with chronic liver disease and chronic kidney disease, because it hasn't been very well studied. And in terms of efficacy, I think the HbA1c reduction study is pretty clear in terms that Imeglimin on its own also can bring down HbA1c. So in patients where if you want to use it as a first line drug, it could be. So far, the guidelines do not support that, but it is well. It is. I mean, you can give it a shot. It is not something that is going to be scientifically incorrect, but so far the evidence is not very clear. In fact, there is no supporting evidence to start it as a first line drug, but you can probably do it. The only thing is that you have to be very sure that there is no CKD or CRD component in the patient.
Do you believe that Imeglimin has the potential to change the future landscape of diabetes treatment?
Like I just mentioned, that when a molecule is acting on the molecule, when a molecule is acting on mitochondrial levels, a lot of things can happen. So a lot of physiologically it could act in many ways where we haven't really thought of. Happened with SGLT2 also, came as a purely SGLT2 inhibitor, but now we have clinically shown, or evidence has shown, that it acts on multiple pathways through which it has exerts its pleiotropic effects. So in the same way, I think Imeglimin, when you consider its mechanism of action, it could act on multiple levels and multiple organs of the body, and not only help with sugar levels but could also help with the comorbidities and other cardiovascular and sexual complications of diabetes.
Any other key points or take home message you would like to share apart from these?
So my key home message would be one, it's a great drug to use in patients who don't tolerate metformin. Two would be it requires a lot more evidence with respect to pleiotropic effects. I think if that is proven, a lot of patients could benefit from that, and we as clinicians could also increase the pool of patients where we can prescribe Imeglimin. And the third one is of course related to safety, that you have to use it very judiciously.